Now, moving on to some other methods of keeping the bones in snugly fitting positions. For example, how we reduce fractures. We have briefly discussed the POP casting, we have discussed continuous traction, functional bracing. But what is the best method of keeping the fractures aligned and so that they can unite is in form of either internal or external fixation. And we will briefly going through what are the different types of internal fixation and external fixation in this section. So what is internal fixation? Internal fixation means holds a fracture securely in form of either plate, screw or a nail, and that you cannot see it from outside. It's whatever the fixation method is, it's actually inside the skin or inside the bone. The greatest danger is actually infection, because to reduce those fractures you will have to give it an incision, you have to go down there, reduce the bone fragments and then apply a plate over it. That means it will require a form of a surgery, and obviously abrasive surgery, infection can occur. Risk of infection actually depends upon different factors. There are patient factors, which means devitalized tissue, dirty wound, etc. The patient had an open fracture in which he actually fell in a form of a farm area, which there was a lot of dirt, grass and pebbles which were in the wound. Obviously that would mean there is increased chances of infection. Then the patient may have other factors as well, such as patient may be diabetic, maybe immunocompromised, maybe taking steroids for rheumatoid arthritis. So all factors may add up to complications such as infection, or it could be surgeon factors such as there may be not enough thorough training, a high degree of surgical dexterity, not enough when you're operating in an OR. Meticulous details has to be looked out, especially to avoid infection, such as the sterilization has to be maintained at all costs. There may be a less degree of adequate assistance as well, or it could be leading to facilities as well. For example, there may be an operating area was such that there was not aseptic measure was not properly taken, and probably the organism was introduced at the time of a surgery or in the peri-operative period. So what are the indications for internal fixation? Indication is fracture that cannot be reduced except by operation. For example, if it's intra-articular, or if there's actually involving the proximal metaphyseal area, for example in case of shoulder, and it's with an intra-articular extension, no, that would probably cannot be able to reduce it by close reduction. You will have to go for open reduction. Fractures that are inherently unstable, we know we're going to reduce it closely, but eventually going to get displaced. Pathological fractures which are associated with usually tumors, that has to be fixed properly by operative methods. Or if it's a multiple fractures, or if there is a case of polytrauma has to be fixed. There is no conservative treatment for polytrauma. Fractures in a patient who present with nursing difficulties. For example, there's a patient had associated head injury as well, and there's paralysis as well, and probably now if the patient is having a paraplegia and now is associated with femur fracture as well, now we need to fix these kind of a fracture, because otherwise we cannot put these patients who already do not have a very good muscle bulk lower down, and along with that will be nursing difficulties for them, as well as to keep them in traction for 4 to 6 weeks. That would be disastrous. Now coming to what are different types of internal fixation. Internal fixation would mean interfragmentary screws, lag screws can be done. Screws that are partially threaded exert compression. This could be in form of circlage wire and tension band wire. Tension band principle means actually converts the converging forces into converts the diverging forces into converging forces, which could be in form of K wires, and using circlage wire or using circlage wire with a screw. Then actually this interfragmentary lag screw sometimes reduces a single fragment into main shaft of the tubular bone. For example, there are multiple fragments which are present, and from 4-part or 5-part fracture we convert it into a 2-part fracture by applying different interfragmentary screws, and then those 2-part fracture the plate can be placed into and can be fixed securely. Coming to the plated screws, for articular metaphyseal fractures, usually we have to go for plates, which could be in form of there are different anatomical plates are available. There are a plethora of different types of plate, and could be in form of DCP, dynamic compression plate, 1/3 tubular plate, low contact plates. Then coming to the these anatomical plates, which could be multiple plethora of plates which are different, available for different areas. For example, for distal radius there are different plates, mid shaft radius there are different plates, and if it's involving the proximal humerus, probably have philos for that. Then there are also for diaphyseal fractures as well. Sometimes in children, for example, if it's involving femur, we can use plates as well. But nowadays, we usually the advent of either this flexible titanium nailing, the plates are actually rarely done for the femur fractures as well. Now there's a neutralization plates. That is actually the plates being applied in neutralization mode. That is, the fractures are just opposed in such a way that the plates hold them together without compressing them, but allows so that they can heal over a period of time. Then the most common type is actually compression type of a mode, in which the plate is applied in such a way that actually it compresses the two fracture fragments together, leading to early union. Or it could be in form of buttressing plate. Buttressing plate is like just you put the plate in there so that you hold the fracture fragments to, they do not get massively displaced from there, so that they can heal over a period of time. Other form is in form of plate. This could be tension band, a bridging type of a plate as well, which can be done depending upon what is the configuration and geometry of the fracture. Different plates can be used in different formats and different modes. Now coming to the complications. What are the different complications of internal fixation? It could be in form of iatrogenic infection. That is, I just told you, there are multiple factors which can lead to infection. The most common is actually a non-union, that despite the surgery, actually the bone has gone into a non-union. If you see over here, this is classical form of hypertrophic type of a non-union. There is a hard fibrous callus which is present in between that, and the bones are actually not united. This could be implant failure, that there may be breaking up of a plate, or the screws get loose due to infection, or there may be pulling out of screws, and this all can lead to complications such as implant failure. Then this is called as refracture. That, for example, the stress rises was such that eventually resulted in a refracture. For example, the patient had nail was done for femur, patient had RT again, resulting in another fracture as well as the broken nail. Now then we have to deal with it, that we may require another type of internal fixation as well. Now if we cannot do some kind of internal fixation, then we may probably have to move for external fixation. Now external fixations is actually reserved as a primary surgery for especially the open wounds. External fixator could be in this form. As you can see, this is a uniplanar type of external fixator, X-fix, or it could be in form of multiplanar external fixator, which is called as Lazaroff. Fracture may be held by transfixing screws passing through a bone above and bone below fracture and are attached to the external frame. Probably the fracture is right over here. They have applied 3 Schwann screws above and 2 below, and they've attached each other in form of these rods, connecting rods, so that this fracture fragment cannot move, as actually held in its position so that it can heal over time. It's usually applicable to tibia and pelvis, although now the Lazaroff is actually being applied almost to all the bones, especially the femur, pelvis, radius, ulna, but that actually requires a lot of experience, plus it's a long learning curve as well to apply Lazaroff on everywhere, but most common areas are actually tibia and pelvis. It could be used for the fractures of femur, humerus, distal radius, even bones of the hand, but with every the indications, the contraindications, there is actually absolute indication. Absolute indications are actually only for open fractures, where you cannot go for internal fixation in form of plate and nail. But others are other indications that you read relative indications for applying external fixators. Indications include fractures associated with severe soft tissue damage, that is the open fracture. Fractures suitable for internal fixation but soft tissue swelling is there. For example, the patient had developed compartment syndrome, and we know that applying plate would actually expose the plate as well as the bone, and then that would be disastrous. Patient with severe multiple injuries, only temporary stabilization is required. There's polytrauma and probably there is multiple open injuries as well, so that the temporary fixation can be done. Once the wound heals, we can move for definitive fixation or definitive internal fixation. Then it could be in form of non-united or ununited fractures, especially when there's angulation, musculoskeletal angulation is present. Then probably laser-off is the best option in which the bone transport can be done and angulation can be corrected at the same time. Or it could be in form of infected fractures. Laser-off is a kind of an option which we can use in form of infective bone union as well, so that we can achieve union even if it's infected, and the patient can wear bait on that infected bone as well. Because if the bone is infected and there is no osteomyelitis present, the metal would actually get infected as well, and then that metal will not be lead to union as well. So what are different techniques of applying external fixator? These include bone transfix actually above and below with the help of Schwann screws. If you see it over here, this is an example of a Schwann screws. The hole is drilled in the bone from a drill bit. Then by use of a chuck, the Schwann screws actually inserted in the same direction. Ideally, 2 above and 2 below, but that does not actually is an absolute criteria. We need to fix upper and lower fragments so that they remain in place, which can be in form of either 2 or 3 Schwann screws as well. And they're actually connected to each other by rigid bars. This is actually a laser-off frame, but as I told you in the previous diagram as well, the rigid bars in case of uniplanar fixators are actually connected together, so the bone remains fixed and the bone ends cannot move relative to each other. Wire and half pins can also be inserted, as you can appreciate it over here. The laser-off wires are actually been inserted, and this is actually a multiplanar frame in which bone can be fixed in 360 plane. Now, entry sites has to be irrigated during drilling. Why? Because drilling actually produces heat, and heat will lead to bony necrosis, and if the necrotic bone is left, this can actually later on get infected and produce osteomyelitis. Fracture has to be reduced by connecting pins with the rods. We have already decided this is the connecting rod, and different frames are actually connected to each other by a different post, and then these wires are actually connected to these rings. Therefore, a stabilized structure is achieved so that the patient can bear weight on it. Now coming to the complications. Again, with every surgery, there are different complications associated with external fixators as well. And the most common is actually damage to the soft tissue. When we are inserting K-wires or Schwann screws, we can damage artery and nerve as well. Then we can over distract. For example, in this case, if the uniplanar fixator is applied, we can over distract the ends, leading to there is a gap between the ends, eventually would lead to non-union or atrophic type of a non-union or malunion. Then this could be the pin track infection, because these pins are actually going from outside, breaching the skin and going into the bone. So if anything which can go through this area, this can eventually lead to pin track infection and chronic osteomyelitis as well. Now coming to the exercises. Exercise, the rehab is very important, especially whether it's internal fixation or whether it's external fixation, because it prevents edema. The elevation is required. Then active exercise results in the blood flow and circulation is good, so that the bone can have nutrition as well. And assisted movement actually results in the decreased joint contractures, and the joint remains supple, and overall the bone healing is actually enhanced, and functional activity is also increased. In this section, we have briefly gone over the different methods of internal as well as external fixation by which we can reduce the bone ends. The internal fixation includes plates and nails. Plates could be in form of simply interfragmentary screws can be done as well, or it could be in form of multiple modes. It could be in form of compression mode, which is the most common, or it could be in form of neutralizing or bridging mode as well. Then comes the external fixator. External fixators could be in form of a uniplanar or biplanar external fixators, or they could be in form of a multiplanar external fixators in which the multiple planes are used. Our ring fixators are a classical example of multiplanar external fixator, which is called laser-off method. Thank you very much. Keep watching sqadia.com.